Welcome to the final part of our GI system disorders lecture, in which we will address children, neonates, and elders. So we'll take a look at GI disorders that are more likely to occur in children, specifically looking at pyloric stenosis, cleft palate, and cleft lip. We'll take a look at newborn jaundice and just a few words about cystic fibrosis. We'll also look at GI pathologies that occur in preterm and newborns, preterm neonates and newborns, and close with the effects of aging on the GI tract. Let's start with looking at kids. Not terribly common, but one of the disorders that occurs in children more commonly than in adults is pyloric stenosis. Now, pyloric stenosis can be both congenital and acquired, but the vast majority is congenital. And in pyloric stenosis, this is actually hypertrophy and hyperplasia of the pyloric sphincter. And remember that pyloric sphincter is that area where the stomach empties and that pylorus, which is the first part of the small intestine. This has actually been related to an increased gastrin secretion in the third trimester of the mother. And is also present in a positive family history. So you look for this on family history to determine whether or not this has happened in other members of the family. Pyloric stenosis is more common in males than it is in females. Because of this hypertrophy and the hyperplasia, it generally doesn't evident immediately at birth, but usually will become evident sometime between the first week up to about the third month of life. It's uncommon for this to manifest itself much after about 6 to 7 months, because remember, this is a hypertrophy and hyperplasia that is a congenital presence. The way this is manifested because of this stenosis, and again, it doesn't evidence itself until the baby is actually eating and using their GI tract. The way this usually manifests is a projectile, forceful vomiting after feeding. And this emesis doesn't have bile in it because the stenosis is above where the common bile duct enters the small intestine. The other piece that is very characteristic of what happens in these kids is that they will have this forceful projectile vomiting after they've fed, and then they are hungry all the time. So that lends you to think that this is not some sort of a systemic illness like a GI bug or something like that that's affecting the baby. There might be something else going on. Clearly, some of the pathophysiologic sequelae that we would worry about would include fluid deficits, electrolyte disorders, and of course nutrition issues, because if the baby's vomiting all the time, they're taking in very little nutrition, and this may actually be a child with a minor stenosis but is manifesting as a failure to thrive. They're simply not getting much food in, and so that means the baby is more likely to not only not gain weight, but also be what some folks might call a fussy baby, because they're always hungry. A second disorder that you'll see in children and not adults, doesn't occur in adults, is cleft lip and cleft palate. And what happens in cleft lip and cleft palate is the first branchial arch fails to develop completely during intrauterine life. And this occurs fairly early in intrauterine life, because this branchial arch is what develops and forms the pharyngeal arches of the mouth. There are suggestions that there are multiple gene and environmental alterations, so this could be a result of folic acid deficiency. It has been related to maternal smoking and maternal alcohol intake, as well as potential genetic alterations of some of the growth factors that are needed in order for the lip and the palate to fuse. So let's talk separately about cleft lip versus cleft palate. Cleft lip is much more common than cleft palate and is the incomplete fusion of the nasomedial and the intermaxillary processes. Now, as I said, these processes usually begin fusing fairly early in fetal life, and so the nasomedial and intermaxillary processes generally fuse within that first trimester, right around the 4th or 5th week of fetal development. Cleft palate is what occurs when the primary palate shelves don't fuse. Now that usually happens about the 3rd month of fetal development. So this is occurring later than cleft lip. And that may also give us a sense of why it's a little bit less common than what we see very, very early in fetal development. So then how would this manifest? Well, the easy way it manifests is the physical appearance. Cleft lip can be minor or it can be more severe, so it comes in varying gradations of severity. But the physical appearance is the first thing that usually keys us in because the lip has not completely fused. But one of the big things that you watch for, because the cleft palate is not immediately recognizable unless you put the finger in the mouth or you notice something odd. Generally, both of these, though, would be associated with feeding difficulties. And that makes sense because when you think about feeding and when a newborn is feeding, they have to be able to form a seal around the nipple, whether it's a bottle or the breast, and they have to be able to form that seal. Well, if there's incomplete fusion in the cleft lip, they can't form that seal. If they have an incomplete palate, once again, they cannot form that seal. The other thing that happens, especially with a cleft palate, is the milk, the breast milk or the formula, moves from the palate up into the nasal passages, and you notice the baby has, the newborn is secreting what you're feeding the baby out through their nose. Now again, this will manifest itself very early in newborn life, and as a result then, surgical correction is very successful in keeping this from being an ongoing problem with the child. We've talked a little bit before about neonatal jaundice, and we know that with neonatal jaundice we want to be sure that we separate the physiologic jaundice from the pathologic neonatal jaundice. Recall that physiologic neonatal jaundice is transient and is generally benign. And this is due to unconjugated or indirect hyperbilirubinemia. And this is just the baby's liver is immature and isn't doing a very good job of processing the bilirubin. In the pathologic neonatal jaundice, you have both a total and direct hyperbilirubinemia. And this is generally due to an increased production of bilirubin. It may be due to poor hepatic uptake or excretion of the bilirubin, and also could be due to a very immature liver. So you might see this in a preterm infant, an incredibly immature liver unable to process the bilirubin, and as a result is becoming pathologic as opposed to physiologic. The biggest risk with pathologic neonatal jaundice is the risk of cognitive deficits and seizure due to kernicterus, the negative effect of the elevated bilirubin as a neurotoxin. The last thing is to once again revisit the system effects of cystic fibrosis. We know that cystic fibrosis can lead to disease of the pancreas, both fibrocystic disease of the pancreas and resulting in pancreatic enzyme deficiencies, as well as can lead to a chronic pancreatitis or can lead to outlet obstruction of that thick mucus. So what happens generally in cystic fibrosis is those pancreatic outflow ducts that are supposed to empty into the small intestine become obstructed by that very, very thickly secreted mucus. This pancreatic duct obstruction causes degeneration and fibrotic changes within the pancreas itself. So that's how you would see how a chronic pancreatitis could occur. There are numerous negative effects of that, but one of the negative effects is that this degenerative fibrotic change that occurs can affect the beta cells, and as a result then an individual with cystic fibrosis could develop diabetes because the beta cells have been altered. And this would be due to poor insulin production as opposed to peripheral peripheral resistance that we talked about with type 2 diabetes. The other issue that's going to occur here is, remember, the role of pancreatic enzymes and their incredible role in protein, fat, and carbohydrate digestion. So when the pancreatic ducts become obstructed and those enzymes are unable to meet the small intestine, you see a failure or a decrease in the digestion of nutrients. They're unable to absorb the fat-soluble vitamins. This will lead to growth failure and osteoporosis because of poor bone mineralization. So numerous GI effects of cystic fibrosis that have far-reaching effects beyond what's just happening within the GI tract. Let's turn our attention to neonates and, in many cases, preterm infants. There are 3 GI disorders that are a bit more common in neonates and, again, more likely to occur in preterm infants. And these are esophageal atresia, meconium ileus, and necrotizing enterocolitis. With esophageal atresia, this is a congenital defect in which the esophagus actually ends in a blind pouch. Now, what happens then with the esophagus ending in a blind pouch, it may also occur with an esophageal fistula. Remember that purely defined, the pathology of a fistula is an abnormal opening between 2 structures that normally do not communicate. So if you have a child with an esophageal atresia that also has an esophageal fistula, that means that they have an abnormal opening from their esophagus, so anything going down to the esophagus is going to enter the hilar region. So it's suggested that what happens, because this is a congenital defect, is the trachea and or the esophagus fails to differentiate early in the fetal development. And that differentiation should occur someplace between the 4th and the 6th week of fetal development. So again, that GI tract and the development of the GI tract in that first trimester is very, very important. This is usually readily recognized very, very soon after birth because the child would have feeding problems. Everything that you're trying to feed them is coming right back up because, again, the esophagus is ending in a blind pouch. The other thing that may happen is you may see an increase in pulmonary distress because of this blind pouch. And certainly if there is a fistula and there's an opening between the fistula and the esophagus and the trachea, then everything that you feed the baby is going into the lungs as opposed to down into the alimentary tract. With a meconium ileus, we have intestinal gland secretions being retained in the rectum. Now remember, meconium is that first stool that the baby passes. And this meconium stool should pass within the first 12 to 72 hours of life. When this doesn't happen, this meconium stays within the rectum, and there are a lot of secretions, and it's very rich in albumin, and all of this is causing an obstruction. Frequently, a meconium ileus is associated with cystic fibrosis, very high association with cystic fibrosis. So when we see a meconium ileus, we generally want to make sure that we have a good family history about cystic fibrosis and may want to also check the child for CF. This is also more likely to occur in a preterm infant. The third disorder that we'll talk about is necrotizing enterocolitis. Necrotizing enterocolitis is more likely to occur, as we said, in newborns, especially in low birth weight babies. Now, this low birth weight baby may be a preterm infant or maybe a term baby of very low birth weight. But this is the most common GI emergency in a newborn. So certainly pediatrics, NNPs, as well as family nurse practitioners have to be very aware of this. And the basic pathology of the necrotizing enterocolitis is due to an immature mucosal barrier. Because of this immature barrier, it delays the digestion of nutrients, as well as is characterized by a slower motility within the GI tract. So what happens then in these babies pathophysiologically is that there's an accumulation of both these are noxious physiologic substances as well as normal substances. This causes damage to the intestine because you've got all of these substances that are collecting, and increases the permeability of the intestinal wall. When you have increased permeability of the intestinal wall, that then facilitates translocation of the bacteria from the intestinal lumen outside of the lumen into the vasculature. This then can lead to an inflammatory response syndrome, as well as the GI effects of intestinal damage. Now, the most common site of necrotizing enterocolitis is either in the terminal ileum or the proximal colon. The other thing that happens, and again, think about where this occurs, terminal ileum, proximal colon, is that there is going to be more gas formed. Remember, you've got this accumulation of stuff that's supposed to be there, and all of these substances are forming gases. Because of the increased gas that's being formed, that then causes pressure. As the pressure within that lumen, the GI lumen, the intestinal lumen increases, that's going to cause vasoconstriction of the vessels within the lumen. With that vasoconstriction comes the usual ischemic process, and then that ischemic process then can cause necrosis. Therefore, a necrotizing, necrotic enterocolitis inflammatory process. The last thing we'll talk about are the effects of aging on the GI tract. As we get older, there are some fairly specific things that happen. One of the things that happens is that as we age, produce less saliva. Now, producing less saliva has two effects. Certainly one of those effects is a nutritional effect. Remember that saliva begins the breakdown of many of our nutrients. And so with that decreased salivary secretion, you may see some nutrition issues. The other piece that you'll see, the other effect of decreased saliva is on oral health. With that decreased saliva, elders, as a result, are more likely to develop a chronic gingivitis, so that oral health and regular dental health become very, very important to avoid the gingivitis, the gum disease. We also know that as many things slow down, so does our GI motility. And this motility occurs in the esophagus, in our stomach, in the gastric area, as well in our intestines. So as a result, then, when you think of things slowing down, you think about other kinds of pathologic processes. So as our transit time decreases in our gastric and in our intestinal, that means that we would experience satiety more quickly. What would that could then lead to negative nutritional effects, because the individual has satiety earlier, doesn't experience satiety very often, and will lead to nutritional deficits because they're simply not hungry. With decreased motility in the esophagus, there can be gastroesophageal reflux disorders, and in the lower colon certainly leads to constipation. In addition to the decreased motility, there is a decrease in the secretion of hydrochloric acid by the chief cells, as well as intrinsic factor within the stomach itself. So with that loss of intrinsic factor, or the decreased secretion of intrinsic factor, what type of anemia does this lead to in an elder? Correct. Macrocytic normochromic anemia, a B12 anemia, because we need that intrinsic factor in order to absorb vitamin B12. As we get older, our mucosal barrier is less healthy, and our intestinal flora, while it remains fairly robust, may also change as we get older. So we still have E. coli there, but some of our intestinal flora may be less productive, and so some of the flora that we need to protect us may be less active. At the same time, with the altered mucosal barrier, in time of an acute critical illness, we worry about the translocation of bacteria that they do have through that poor mucosal barrier of the intestines. And then last but not least, when we think about the effects of aging, think about our liver. As we get older, the liver has a decreased ability to detoxify as well as regenerate. Yes, liver cells do regenerate. They're constantly doing maintenance. But because of this decreased ability to detox and regenerate, this can lead to pathologic changes, especially if they are unable to metabolize medications. That then puts the elder at increased risk for adverse drug reactions because the liver is our metabolic site for most of our medications. So in this somewhat short section, we've talked about things that are more common in children. So we've talked about cleft lip and cleft palate. We've talked about pyloric stenosis. We talked about hyperbilirubinemia. And then we also spoke a bit about the effects of cystic fibrosis. And many of the things that we talked about, especially pyloric stenosis and the cleft lip and palate, will alter or has potential negative nutritional effects, as well as the cystic fibrosis nutritional effects on the child. When we think about neonates, things that occur very, very early, we think about what's happening in both the esophagus, in the ileus, as well as what may be happening in that terminal ileum and the proximal colon as we think about a necrotic enterocolitis. And then last but not least, as we have talked about so many times, as we age, we change. And those changes are important not only in our overall health, but how these changes, whether it be less saliva, less motility, or a liver that isn't as good at detoxifying our medicines, can lead to additional pathologies. Thank you for your attention. Let me know if you have any questions.